I want to share you what are the lessons we have we learned. It's not working. No, sorry, I'll do here. Okay, from the aortic valve repair in the adult, we can transmit it to the pediatric or to the congenital things. For sure, what we've learned that at the beginning of our experience that severe AI was contraindication for repair at that time, mainly in the presence of aneurysm. Now we know that severe or mild, whatever, is excellent candidate for repair, not really contraindication. What learned also that perioperative assessment of the valve to understand the mechanism of AI and in the pediatric population also of stenosis, it is really of paramount importance. We should really understand and assess, and mainly by the transesophageal echocardiography. What mainly in the pediatric population, what is really very important also is the quality of the tissue and the quantity of the tissue. And we know that one of the most, in any valve repair, one of the most important determinant of durability of the repair is the quality and the quantity of tissue. Because if you don't have, the durability is compromised somehow. We have to apply the proper surgical techniques to address all the lesions, and you will see, or we know that in the pathophysiology of the aortic regurgitation, we have sometimes 1, 2, 3 lesions giving the aortic regurgitation, and we should address all lesions giving the aortic regurgitation in order to achieve a good aortic valve repair. And one of the things also we'll learn from the adult that exactly like on the mitral side, when we repair the valve, the leaflets, we should stabilize the annulus, what we call the functional aortic annulus. Now, if we achieve a good immediate result, that's the guarantee that we will have a durable repair, providing to have a good quality of tissue without any residual aortic regurgitation. So, in order to see with you how we can apply all those principles in the pediatric population, I will go with you really with some small lessons, what we learned from the mitral valve, what we learned from the aortic regurgitation pathophysiology, and mainly also what we learned from bicuspid aortic valve. So that's usually, as we've seen yesterday, that the 3 things we have to focus on, and also in the pediatric population, that the free margin of the leaflet, the HCG, and the VAG. Those are the 3 things when we can work in order to achieve, to obtain functioning valve. Free margin, HCG, and the VAG. And in the pediatric population, you will see that we will also need the quantity of the leaflet or cusps. So we have 3 leaflets, as I said. We did this classification of the aortic regurgitation. This is somehow also applicable in the pediatric population, type 1, type 2, type 3. It is only to see that when it is very rare to have only 1 lesions, and many patients may have a dilation aortic annulus and prolapse or whatever, and we have to address all those things. Now, if you look, and that's when we are reconstructing the valve, if you look to this relationship, that the motion of the leaflet, it's a relationship between the free margin length and the insertion length. If we have excess, you have excess motion. If you have excess free margin, you have excess motion, you have a prolapse. So you have to decrease, to shorten the free margin in order to have to restore the motion. And the same, if you augment the insertion length, let's say if in bicuspid aortic valve, the insertion length is so big, so the motion is less. Now, in order to restore the motion in bicuspid aortic valve, we have to decrease the insertion length, which is the VAG, in order to restore the motion. So if you keep this equation in mind, it can help you to resolve a lot of let's say, of problems when we are reconstructing the aortic valve, the free margin and the base of implantation, and the relationship between those 2 parameters is really give you an idea about the motion of the leaflet. You can see here that if you change the commissure, if you are reconstructing, if you are change the commissure distance, you may induce prolapse or you may induce a restriction if you augment the distance between two commissures. It is really very, very important to have this in mind. And so the goal, as you know, to repair the valve in the pediatric and the adult, that's the same. We have to preserve the motion of the leaflet and to stabilize the annulus. Keep this in mind. On the aortic side, not only the coaptation, but also the motion of the leaflet. It is much more important on the aortic side, the motion, than on the mitral side. It's really very important. So we know also that in the adult population, and you will see that also in the pediatric population, when we do the reimplantation, we take care of both the annulus and the HG. That's intrinsic to the technique itself. But we know also when we do this kind of surgery, we may change the configuration of the leaflet, so we have to check the free margin and to do a repair of the prolapsing, possible prolapsing leaflet in order to achieve a good coaptation and the permanent and the durable repair. So keep all those things in mind. So that's the understanding of the mechanism, the role of the functional aortic annulus, and as you will see, the role of the leaflet is really, really very important. And we learned that from the adult, and we are trying to apply all those same principles in the pediatric population. Bicuspid aortic valve also, we learn a lot on the adult, and it is now we have more and more pediatric population, 15, 16 years having this pathology. And we are trying also in those patients to obtain, to restore the functional aortic annulus, as you can see here, the importance of the anterior part of the aortic annulus. We should really focus on this area. It is very important because in some patients in the pediatric population, when we have a small annulus, relatively small annulus, sometimes instead of having complete circumferential annuloplasty, sometimes it is really enough to do anterior from trigone to trigone, but anteriorly partial annuloplasty in order to really restore the matching between the orifice and the quantity of tissue. So having this in mind really can help us in the pediatric population not to do a complete annuloplasty, only anterior one, exactly like on the mitral valve, we do the posterior partial annuloplasty, and on the aortic side, that's the same. Only doing anterior annuloplasty in pediatric population when the orifice is really very small can help you to restore the matching. So that's I mean, now for the bicuspid aortic valve, that's the same in the adult. We have a lot of bicuspid aortic valve, type 0, type 1, type 1, and type 1 we have 2, the prolapsing and the restrictive. I will give you some examples before doing that. So I will go a little bit faster than this. Now, the annuloplasty in bicuspid aortic valve, as I said, should take care of the anterior part. In the pediatric population, we should not go to the circumferential one, as you can see here. So doing only the anterior one can help you to restore some kind of matching. So that's what really we like to have in the pediatric population, maybe circumferential, and we can discuss about that later on. So that's the general principle in the adult. How we can look to the pediatric population, let's say. I try to divide the patients with the aortic regurgitation in two groups. Groups when we have enough tissue, adequate and excess of tissue, so that in those situations we have a leaflet prolapse and annular problem, and we have a lesions when we don't have adequate tissue, or the quantity is not adequate, or the quality also. We have lack of tissue, and in this situation we have not prolapse, but in the majority of patients we have a leaflet restriction. If you go to the first group, we have a bicuspid aortic valve, you have the aortic root aneurysm, Marfan, Ehlers-Danlos, all those connective disease. We have the submembranous VSD, which is really in this group, we have a mainly leaflet prolapse, while in the other group, we have the bicuspid with restrictive raphe, not enough effusion. We have the dysmorphic valve, mixed disease, mainly post-balloon, and we have the unicuspid valves. So we have those two groups, and the surgical techniques is different in each group. And I will give you an example of each of one. So the etiology can be unicuspid, bicuspid, quadricuspid. You can connective disease, supra-aortic stenosis, and you can maybe say 2 words on that. Supra-aortic stenosis in patient who is not really pediatric yet, but he's 18, 20 years sometimes. We have those patients, and with the good quality of the tissue, so in those patients, doing a remodeling, Jacob operation, is sometimes really well indicated. We can have a good result with that. We know that usually the surgical technique uses is the three patches, but in quite, let us say, growing up patients, the remodeling technique is acceptable. Now, that's the bicuspid aortic valve access tissue, and you will see that in the pediatric or adult, the major problem is the annular dilation and the prolapse of the anterior. So the idea is fix the aortic annulus, as you can see here. You can see that. Fix the aortic annulus, and usually this patient has 18, 20, 25 years. It can be more, it can be less, but that's the patient coming for aortic valve repair. So the main issue, as I said, is to stabilize the anterior and to repair the free margin. The reimplantation technique is in our experience, is the best indicated for bicuspid aortic valve, regurgitated bicuspid aortic valve, sorry. Now, what is it, this one? That's how we, for the root aneurysm, I think, and we will see it with the next speaker, the same technique as on the adult, and our preference goes always to the reimplantation technique, because we take care of the inflow and the LVOT and the HCG. The third group, and we have more and more patients coming with that, is the autograft failure. Autograft failure can fail by dilation of the aortic root or by prolapse. Dilation came usually later on in the evolution, 8-10 years after the surgery, while prolapse can come a little bit earlier, and mainly due to technical problem. So we can also, in those patients, we have now, in our experience, out of 600 ROS, we have around 50 coming back for autograft failure, and we were able to repair all those patients, but 2 patients we had to replace them. So it is possible to save, to preserve the autograft. I give you an example here. I don't know if it's working. It's not working. I don't know why. So this is I mean, an example of autograft failure in whom we did the reimplantation technique. It is working here. I'll show you small examples. So the regurgitation is very small. We have a dilation of the aortic root. And now you can see here one of the big reasons of this redo, that the autograft was so long. We are no more doing this kind of long autograft. We are implanting as short as possible. But anyway, we have a dilation of the supracommissural segment of the autograft and also of the autograft itself. Now, depends on how you reinforce your first plan at the first operation. Sometimes it is quite hard to dissect this area, because if you use a pericardial, if you have used pericardial strip at the beginning or Teflon or whatever, it is difficult. But the main issue is really to liberate, to free the autograft from the old aortic wall, and to make this LVOT pliable, and you can really do the reimplantation technique. Another, if you don't have aortic regurgitation, the technique to be used is the remodeling, because you don't have to really dissect the proximal plane. So if you have aortic regurgitation, we don't hesitate to go for reimplantation. If you don't have aortic regurgitation, or if the annulus is not dilated, we go for a Jacob operation, the remodeling. So it is possible to save also autograft, and believe me, in the 50 patients I have to reoperate the autograft, I never see a calcification of the autograft. Always the tissue are pliable. The only thing you can see is sometimes elongation due to some elongation of the free margin
due to the dilation of the autograft, but never calcification. So it is always possible to save. These are patients who had came to me 1 year after the surgery, and you can see here, and was operated in another institution. The only lesion here is the prolapse of the right, and that's technical one. So with one stitch, it is possible really to save this autograft. You, by definition, as I said, the free margin, the prolapse is elongation of the free margin. With one stitch, you can save this autograft, and you can see here that the coaptation is restored. The only thing that you have to discuss about is should we fix the functional aortic annulus, the AVG, the VAG, and the HCG. In our experience, we'll go for fixing, for stabilizing, but it is possible also if you have enough tissue and we don't have let's say, lack of tissue, you can only by this stitch repair this valve. So autograft is possible to repair in the presence of the regurgitation, prolapse, or dilation. Now, one thing to do is when we are reconstructing, let's say, unicuspid, or if you have a commissural fusion, and you can see that it can help you in some pediatric population. You do your commissurotomy, but your commissure is lower than the others. As you will see, the opening is perfect. It is not, pediatric one is adult, but I show you this example in order to show you how we reconstruct the annulus, the commissure, when the commissure is lower than the others. And in order to show it very well, I draw a line on this. You can see that's the HCG, what you have in blue. So you can see that your commissure is lower than the others. So if you want a durable repair, you have to reconstruct the commissure over there. And the way to reconstruct is with this small pericardial patch, as you can see here. It's a butterfly. We described already this technique years ago. With one patch, you can go really from what we call the butterfly. We align the patch first on the interleaflet triangle up, yes, and we align it after to the aorta, and after that we trim it to the free margin. To trim it to really to correspond to the. I cannot go further. Faster here on my video, but the idea, I will stay 1 second here to see if you can see it. After that we will apply it, and so it is necessary when you see that the commissure is lower than the others. Commissurotomy is not enough. We have to reconstruct, and you can see here, that's the way it is a quite open one, quite interleaflet triangle. After that, we trim it you attach it to the free margin, and you trim it over there. Go faster a little bit. Okay, that's the one technique. You can use two patches, and that's. I don't know if you can go a little bit far. No. Go far. No. Okay, now we try to trim it. Now it is fixed on the aortic wall and on the free margin of the leaflet. It is usually good to cut it a little bit higher than usual. That's, you draw the line how is where you have to cut, and you can at the end try to approximate all the things. And you can see here in some patients we don't hesitate to go and do a reimplantation technique. That's unicuspid valve. And you can see we have the same. We first try to cut all the resect all the diseased tissue, all the raphe. We have tried really to free the raphe, because by cutting the raphe, you can really gain in mobility. That usually the right coronary part is always atrophic. So you have the none and the left. You will be right, and you have to reconstruct this valve with one or two patches. So usually you dissect the externally the commissure we draw on the patch the way you have. First, we align it to the aorta. It is one single technique, and after that, you have really to trim it and to restore the two leaflet. You can cut there, and now, yeah, I mean the technique is described somewhere. I don't know. Now that's another patient, exactly the same, lack of tissue, unicuspid. We always try to cut resect the diseased tissue. When we reconstruct the commissural, you should pay attention not to be a little bit far from the right. So you have really from the right coronary ostia. You can see here, we have enough tissue. We liberate, we cut all the diseased tissue. So that's the second group of the patients when we have a restrictive or don't have enough tissue. So the idea we are obliged to add many tissue. Now that's what is this patient. I don't know what is that. It is not working. I don't know why. Sorry. I cannot make, sorry, that's the reconstruction. Now it's working. More or less the same post balloon. You can see here where the problem is. Usually the majority of cases, that's the right one is atrophic. And we have really to assess first the quantity of tissue we have. Usually half of the valve is acceptable. So you have really to open. And sometimes you do some kind of myectomy in order to have a large orifice. And in this patient, we will do 2 patches. Sometimes we do only 1. But the main thing is really to cut all diseased tissue and to do some kind of myectomy. And the third thing to pay attention on is the place of the commissure, just far from the coronary ostia. 1 or 2 stitches. And you can really obtain I think that was core matrix. We stopped using core matrix at that now because I had to redo this patient because the core matrix disappeared. Now this is another patient. I don't know what is that. This is this patient's head. I don't know what is that. Let me see. I forget what is that. Oh no, that's a patient with it was tricuspid aortic valve, lack of tissue. So what I'm doing in these patients is what I want to show you is anterior annuloplasty. Let's see, let's go. It is not working, I don't know why. This way here. So the idea is really from this area. And we cannot see from the, I do some kind of annuloplasty from the right trigon anteriorly to the left trigon with Gore-Tex, really in out. So and you can tie it on Hagar. Yes. So we have to dissect do some kind of deep dissection. You can see it is tricuspid aortic valve, dysmorphic. I think he was 12 or 13 years. So I was really not willing to have a circumferential annuloplasty. So I went from 1 trigon through the insertion of the leaflet through the annulus with Gore-Tex 2.0 is big one, and stop at the left trigon twice, and take after a Hagar and tie this. So it is really in the pediatric population doing only partial annuloplasty help you to avoid the I think what was 17 or 19 this one, and you tie on that 17 I think. Now that's another patient with what I don't know if it is working. It is not working. Yeah, it is working. I forget what is that. Yeah, that's the patient who had switched 10 years before, and they had a severe aortic regurgitation now and dilated root. So we are cutting now here the pulmonary trunk, which is anterior to the aorta. And you will see that we after aortotomy, was possible to dissect. The valve was tricuspid, and we were able to do. We are here. We were able. You will see, that's the this switch here. Was transposition of a great vessel, and you will see that the valve was okay, but was dilated, very dilated root with aortic regurgitation. That was the indication. Now that's the left or right, I don't remember. So the coronary arteries are not at the same place. Now we are clamping this, and yeah, that's the. So even in this difficult situation, we can save the valve. We don't have to replace it all the time. And we have 2 patients now with switch and preserved valve 10 to 12 years after the surgery. So in conclusion, in our institution, let's say, following this period, you can see that nowadays, the last 10 years, we are more repairing the aortic valve than replacing. And we have at least, if you have to add the tissue, it is only to postpone, let's say, the Ross operation, because we are also very fan of Ross operation. And you can see here that the overall survival of those patients, pediatric one, are really very good at here it is 15 years. Freedom from stenosis is acceptable. At 15 years, it's 60% are free. And freedom from reoperation and replacement, you can see here at 15 years, is more than 80%. Thank you for your attention. I'm sorry.
Thank you very much, Professor Ekri. Any question? Yes.
Yeah, I mean, I'm a little bit high. I am a little bit high on the right trigon. I start a little bit higher than usually, and I go through the membranous septum. So I close the membranous septum. I'm not lower than the membranous septum. I'm really at the level of the membranous septum, so I am sure that I'm in the fibrous part. There's no block over there, and you go. Okay. It is really very, we've done 4 or 5 patients now, and no stenosis after that, because as you know, sometimes when we do the complete, you will have this problem of a gradient.
And do you like treated pericardium or fresh pericardium?
Depends. We use everything, but usually the majority of cases we treat.
Thank you.
Yeah. Label in the children is when you recommend that it's less thick leaflet. Less thick leaflet is not enough tissue.
Yes.
How do you know that? You have to. I saw you in the video. You extend the leaflet, and some students have just like fibrotic. It's not much. You will do the annuloplasty or extend.
I mean, if you have enough tissue. I mean, as you know, the goal of the repair is to restore the matching between the tissue and the orifice. If you don't have enough tissue, sometimes you reduce the orifice, so relatively you have more tissue, but you have to avoid the gradient. And sometimes you cannot do the annuloplasty, so you have to add tissue. So you have always this balance between orifice and the quantity of tissue you have inside. If you cannot really reduce the annulus, you have to add tissue. And shave, sometimes we shave as possible. We try to respect as possible, or to be economic as much as possible, the quantity of tissue we have, mainly in the pediatric, because it is sometimes this bad tissue sometimes is better than pericardium.
Yes. Thank you very much.
Okay, so we'll have aortic root and leaflet
Yes. Yes, thank you very much for inviting me to. Hard to say today because I have to talk about the aortic wall repair in front of the master of aortic repair, the master of the Jedi of the world. So I try to do best, but I limit our technique to the root replacement for valve sparing and some add-on the leaflet repair, because most of our leaflet repairs, Professor Elkuli already talked it. Okay, the valve sparing root replacement is established 25 years ago, and meaning we try to preserve the aortic leaflet and correct the root disease with excise the aortic wall disease and keep the leaflet and coronary artery that normal. And we use the Degenerative graft to do the two techniques. That the one is the remodeling, is meaning you cut the end of the Degenerative to the tree trunk, T scallop, and you suture to the aortic wall that you remain. And another one is reimplantation. You cover, you implant the whole aortic root inside the Degenerative graft. The both techniques have benefit or and disadvantage. Yes, remodeling is look physiologic because you not fix the tricone or preserve the annulus function. It can move in the systolic and diastolic. But the problem is the technical is look simple, but it's not simple because bleeding is much more than the reimplantation. And very important that this technique it not prevent the annular dilatation. So when you would like to do this technique, you have to do the add-on the annuloplasty, especially in the case of the genetic disease or bicuspid aortic valve. The reimplantation, yes, you cover the whole root in the Degenerative graft, so it meaning you fix the tricone, you fix the annulus, that cannot movement, so it look like you destroy the physiology of the aortic root. But the advantage, the very advantage that to prevent the dilatation of the annulus in the future. In the year 2004, the Ceylon report the cases both remodeling and reimplantation, and most reimplantation in 296. They follow 25 years, and most of the patient is a Marfan. So yeah, you see in the graph when they compare the reimplantation and remodeling in 18 years, you see that the durability of reimplantation look better. So why the recommendation in the ASCVTS they did not recommend the remodeling to do in the genetic disease because you cannot prevent the dilatation of the annulus. But if you talk to in the European, it cannot accept that because the European they say that they should be do the annuloplasty in every case. So in the ASCVTS recommend the remodeling in the case with the dissection or the normal aortic annulus. Reimplantation, yes, it had one recommendation to do root repair in the patient with the genetic disease or all of disease. Our unit do the CABG1 from 2002, and we adapt to CABG5 in 2014. Yes, in Thailand we have this Warsaw gap, but the problem of reimbursement, so we have to do the technique that more simple and can use the tubular graft developed from the Sakamoto techniques. Yeah. This video it show the technique of reimplantation. Yes, the first one that you see, every time you have to cut the aortic wall out and keep the aortic wall remain around 5 millimeter, and you prepare the coronary button in left and right. Actually, I still evaluate the structure of the root first. The very important in our technique is leaflet. You have to have the normal leaflet or not restrict too much. And we also size the intercommissural height length and also the annular diameter. We still use the how to measure the graft. We use the classic David Fendel formula. Select the graft. If you need to do the David fight with the technique, you have to add on 6 millimeter, and we placate the end of the graft because they try to reduce the graft to the normal annular size or normal reimplantation size of the graft. Usually, we use, if the David one, we use 28 or 30, and after that we put the suture that anchor the graft. We use only knife. We don't use the patchet because I think patchet can produce the fibrosis and sub-aortic stenosis in the future. So we wrap the root with the graft and we tie the suture under the hair dilator and we fix the commissure. You did not need to fix the commissure in the same size because the commissure is not the same. Last 2 years we used the Professor Ekuli, we measure commissural height every height and we mark that to fix the commissure. And you running the second layer is very important because it hemostatic suture. So with the fluoropolin, we still use the saline test or suction test anyway. And after you fix the commissure, you can repair the leaflet at this point. And we reimplant the both coronary artery with the fluoropolin and in the elected heart. And after finish the coronary reimplantation, we placate the intercommissural graft to the annular size again. So because we know that the annulus and the ASCVTS is different not much, so we maybe reduce the ASCVTS to the around 10% more than annular size, and we anastomosis the good. You check the function again, and if you need to repair the leaflet, you do at this time. It may be better, and you connect to the ascending. This patient have to do the arc replacement. We do the arc replacement, but in the only one tubular graft. So you see, this bouncing is just like the with 5 is 2 graft, but no, only 1 graft. This echo is of the patient with the with 5 technique is, you see, is bulging at the sinus, and the function is aortic valve is very well. No AS, no AR, no gradient, very low gradient. For the CAS repair, actually in our first 5 years, we don't do the CAS repair. If the problem of the CAS, we don't do the AV sparing. After that, we learn a lot from the root replacement, and we start to do the CAS repair. We follow just Professor Ekuli that he talked earlier that the CAS repair is meaning actually the functional of the classification of the AR is not only one disease. It may be add on the type 1 and type 2 together and type 1 and type 1D because you have to collect the sinus vasova, or sometimes you have to collect the annulus and add on with the leaflet repair. Actually, for the cut perforation is CAD2 is you can fix it the pericardial pad, but I don't do that in the AV sparing because we do in only the case that infective endocarditis and only one case we can pad the leaflet. But in the past we try to collect the fenestration, and we know that the very important factor for the failure in the future. You don't need to collect the fenestration if it not affect to the aortic valve function. It's meaning it not produce the aortic regurgitation. You leave that. better than you try to patch or to do anything. And in the past, we try to do the 3 or 4 cases of free margin reinforcement, just like Dr. Akuli said on this. But I think it's really difficult technique to do that we use the cortex and running suture over the end of the leaflet. And the problem is, when the root is collapsed, it's very difficult to adjustment. So now, only one technique that we use, the plication of the leaflet, free margin. I trust that because it's simple and reproducible. Most of the case now, after 3 years, we use this technique. It's really good results. Our unit, in 15 years, we did David operation around 65. Also, we do some part of remodeling around 10 to 15 cases, but we did not include in this analysis. And most of the patient is a Marfan. And actually, you see that we call the idiopathic root lip aneurysm, but in the past, we don't know that in Thailand have the loidis also. After that, we check this group of the patient, we know half of it is loidis. So maybe idiopathic, we have to back to reorigate again. That may be loidis. So we do the David one is allow more than 90%, but we did the David 5 around 8 cases. 4 cases we need to repair the leaflet. That I said that we don't do that in our experience, and we also do a complex aortic arc repair in the aortic aneurysms, and also elephant trunk procedure or forced elephant trunk. We have 1 cases mortality, and I usually stay around 1 day. We don't have stroke. We have 1 case that myocardial infarction in the aortic dissection, but just a major problem is prolonged ventilation time, more 24 hours. We have 2 cases paraplegia in the dissection, and we have 2 cases of late death. We have reoperation for aortic valve replacement is 3 cases of 48%. Most of this is we try to repair the fenestration. So after we stop to do that anymore. We do the free margin plication or leave the leaflet leave the fenestration when it not affect to the aortic valve function. So our 12 years reoperation around 80% and survival 95%. So in our series, we review that the very important factor to failure to root repair is or failure when we classify in moderate to severe AR. We know that the cast repair is very, very important factor increase the failure rate. And another one is graft size. Actually, we use the 28 or 30 is not more than this. If we try to increase the size, maybe failure rate is high. Also, David 5 is also because David 5 you had to shoot the 36 or 38. So I don't know. Maybe that we have to think about again that we still use the David 5 or not. So I think AV valve sparing replacement now is a bit surgical option for the treatment of root pathology. We have multiple techniques add-on with the valve sparing to improve aortic valve function. The very important, you have to know the anatomical feature and function of the aortic root, and we try to correct abnormality to normal and maybe successful to correct the aortic regurgitation and improve durability. Repair fenestration is high risk to failure to repair, and I hope we can develop our center to just like the Basel, we repair all the cases because now we do a lot of cases congenital. Today I got a lot of knowledge for repair in the children. Thank you very much.
Perfect. Excellent. Okay. Tell me, you have why fenestrations is difficult? You have repaired the three fenestrations at the first surgery, or?
No, repair it 4 fenestration, 3 it failed.
And the repair was what, by Gore-Tex?
Yeah.
And what was the reason? The calcification or what?
I think it's a retraction of the leaflet, fibrosis.
Fibrosis of the leaflet.
Yeah.
Yeah, that we were discussing yesterday. First, I think Gore-Tex sometimes induce calcification, and I stop, mainly in bicuspid valve. And the second, I'm less aggressive with fenestrations now. Leave the fenestrations, don't touch, unless they are really have something to do with the regurgitation. I think that's any questions from the audience? No? In acute days, you are doing only reimplantation now?
Yeah.
No, Jakub.
The girl that do the Yakub now, he stay with them, but she will back this year. She will do it or not, I don't know, because the Yakub now she did that 15 case now, 2 cases reoperation.
Redo. Oh yes. Stop, Jakub. It's not good operation. If not, we will conclude here and stop. Thank you very much. Thank you.
afternoon, ladies and gentlemen. Welcome to free paper session for coronary artery disease this afternoon. We're gonna start with Dr. Aya Saito. Are you ready?
Good afternoon, ladies and gentlemen. First of all, I would like to thank the Society to give me the opportunity to present my paper during this meeting. And today, I would like to present the trends of isolated CABG in Japan from 2015 and 2016 using the data, our national database, which is called Japan Cardiovascular Surgery Database. As a background, the Japan Cardiovascular Surgery Database, which is usually called JCVSD, is a nationwide registry of clinical database started 2000, which dataset are quite similar to STS database. And we have been making a report of the operative outcome of cardiovascular surgery biannually using this database and by the category as to isolated CABG, valve surgeries, aortic surgery, and congenital heart surgery since 2013. And this time, I would like to present the result of the analysis on the isolated CABG using this database from 2015 and 16. The patients and methods is presented in this slide. And the study period was for the whole 2 years, starting from January the 1st, 2015 through December 31st, 2016. And the detail of analysis were focused on the pre-op patient's characteristics, a combination of graft choice, especially focusing on the status of ITA use as well as the saphenous vein graft use. And the graft choice for LAD revascularization was analyzed. And the last thing was the perioperative outcome. This slide shows the pre-op patient's characteristic. And I also highlighted in the quite particular characteristics in a red line. And the smoking population is quite high in my country, and more than half of the patients is the recent or history of smoking. And more than half the patients are diabetic. And more than 10% of the patients were on renal replacement therapy, and quite symptomatic patients. And a quarter of the patients have the history of PCI. And this slide shows the combination of graft according to the frequency of use of ITA as well as the frequency of use of saphenous vein graft. And the column on the left in the slide shows the elective cases, and column on the right showing the emergency and urgency cases. And apparently, single ITA use is more frequent than the bilateral ITA use, which is quite understandable. And this slide shows the combination of graft in the cases which were done with all arterial grafting. And for the elective cases, the surgery, all arterial grafting was done for the quarter of the patients, which is written in somewhere here. And even for the emergency cases, 1/6 of the patients were done with all arterial cases. And so I think the main surgeon in my country is quite trying to do the surgery by all arterial grafting. And the interesting thing is more than half of the cases were done using bilateral IMAs. And this is interesting to see that the combination of graft, the tendency of graft choice, arterial graft choice is similar, even though the cases were done electively or urgency cases. This slide shows the combination of graft by age group. The surgery was most frequently done for the patients at the age of 60 and 70s. And of course, emergency cases were done with, more cases were done with the single IMAs. Because our CABG patients were done with bilateral IMAs, and I was interested in knowing that whether the right IMA had the more chance of to be used for the LAD revascularization. So I looked at the detail of the data, but apparently most of the cases were done with Lima to the LAD anastomosis, and about 80% of the cases were done in that fashion, regardless of the age group. And from this slide, I would like to show the post-op result. So starting with the mortality rate. So the graph on the left shows the overall hospital mortality. And I also showed the comparison with the previous report and this time report. The overall hospital mortality was 3% since 2013, and the result is quite stable. And I also looked at the result according to the cardiopulmonary bypass use or not. And on-cap cases showed, especially on-cap case with emergency case presented a really high mortality rate with a 12.9% for the emergency on-cap case, whereas the for op-cap case, the elective case as well as emergency case had a quite low mortality rate, which the op-cap result is quite stable in my country. And for each complication, as shown in the slide, for the bleeding complication, it is remarkable that the on-cap emergency case has a higher bleeding complication. So as the stroke incidence is also high for the emergent on-cap case. For the deep sternal wound infection, did not show any difference between the elective and emergency case for the on-cap. But for the op-cap case, there was a slightly higher incidence for the emergency op-cap surgery. This slide shows the incidence of prolonged ventilation more than 72 hours. And apparently, emergent on-cap case has a higher rate of prolonged ventilation incidence, but the overall incidence itself is decreasing since the last report from 2013 and 2014, which shows a 7.2% and decreased to 5.2% from the this time report. And I think this is a kind of reflection of the idea as to fast-track post-op management of the patient with a faster extubation from the ventilator. This is my speculation. For the pneumonia incidence is a 2.5% this time. The incidence itself is quite low, but for the emergent on-cap cases, the incidence is quite high. The last thing is atrial fibrillation. The atrial fibrillation in general presented a 12.4%, which is quite low compared from the other reports from the other countries. And if we looked at in detail, the incidence between the op-cap and on-cap or emergency and elective cases didn't differ that much. And this table shows the summary of the complications, and also I looked at the comparison between the on-cap and op-cap statistically. And most of the complications occurred more frequently in the on-cap cases with the statistical significance. And most significant was the operative mortality. So if we try to look for the paper reporting the clinical outcome using the national database, we really don't see that many journals regarding this type of report. The only thing I could find was the STS report, and the most newest one was from 2018, and the post-op mortality rate was 2.2%, which was a little bit lower than our report this time. But it is not easy to compare the the number itself, because early 2019, there was another report from the Annals of Thoracic Surgery, which compared the isolated CABG result for the Asian population using the Japanese National Database and STS database. They did a simple comparison between those two databases for the same race from the different countries, which shows the pre-op patient characteristics is very much different, even though the race is the same. And the operative procedure is also different. And post-op result was very much different. So it is really hard to compare the results from the journal, the publications. We really have to be careful about that. And as a conclusion, this is a report from the most recent clinical result from the Japanese Clinical National Database. And we can also say that it is really important to have the nationwide registry of the clinical database, because the result might be really different from the reflecting the social background, a cultural background, and the racial background. Thank you very much for your attention.
Any question from the floor? Thank you very much for the good database. I have a question for you. Can you explain your result in Japan is different from the US? I mean, like the compare between the off-pump and on-pump result is quite different. What can you explain on that, please? Can you explain why it's different? Like off-pump, you have a lower mortality in off-pump or in stroke?
I think the background of the patient might be different, because this is we didn't do the risk adjustment for the patients receiving the on-pump surgery or off-pump surgery. So the on-pump CABG cases might be more the sicker patients, a higher risk patient. I don't know the detail, but that might be one reason. And the other reason might be the bad side of the pump use, maybe the cerebral stroke thing or renal insufficiency thing. Did I answer the question? Maybe. Thank you very much.
Okay, let me invite the next speaker, Dr. Otomo Hino, with the topic of off-pump versus on-pump beating coronary bypass grafting, short and long-term result in the institute. Please.
Hello, my name is Atom Hino from Department of Cardiovascular Surgery, Tokyo Medical University Hospital. And I'm very honored to stand here and get a presentation in ASCVTS. So I want to start my presentation. The title is Off-Pump versus On-Pump Beating Coronary Artery Bypass Grafting, the short and long-term result in our institute. Many papers were published about off-pump versus conventional CABG, and off-CAV has been demonstrated to reduce the perioperative complications and mortality compared with conventional CABG. But how about on-pump beating heart CABG? The superiority of off-CAV compared to the beating heart is still unclear due to the small number of studies. Various conclusions of off-CAV versus beating heart were published in the past meta-analysis study and other retrospective observational study, but the outcomes were still controversial. The aim of our study is to compare the short-term outcome and long-term mortality and major cardiovascular event between off-CAV and beating heart. The definitions of MACE in this study is including myocardial infarction and postoperative PCI and reduced CABG, cardio-related death and stroke. This study was conducted as a retrospective observation from January 2013 to December 2015 at Tokyo Women's Medical University Hospital. statistic analysis is as shown below. 120 patients underwent CABG in the period, and we excluded low ejection fraction, less than 40% in the preoperative echocardiogram, and excluded conventional CABG patients. So finally, we selected 47 patients underwent off-cath and 54 patients underwent beating heart. This table shows the characteristic of two groups. In the two groups, there's no significant differences in preoperative characteristics, including Euro square 2 and SDS score. Of course, there's no significant difference in preoperative LVEF because we excluded patients less than 40% EF. This table shows the operation data. Operation time is significantly longer, and the number of grafts are higher in the beating heart group compared with off-cath group. And there were no significant differences about kinds of grafts. Mainly, we used single ITA plus saphenous vein graft. And higher number of patients in off-cath group were used preoperative IABP. This table shows short-term outcomes. Hospital stay in the off-cath group was significantly shorter than that of beating heart, and there were no significant differences in post-operative EF between two groups. This shows long-term mortality. We follow it over 5 years, and mean follow-up time for present analysis was 48.3 months. On using Kaplan-Meier estimate, the off-cath group provides significantly better long-term mortality compared with beating heart group. And this table shows the cause of death in the two groups. There are no significant differences, but non-cardiac death were higher percentage in beating heart group. And this table shows long-term MACE. On using Kaplan-Meier estimate, there were no significant differences on long-term MACE between off-cath and beating heart. B summarizes as follows. The number of graft anastomosis in off-cath are significantly fewer than that of the beating heart group. The off-cath group demonstrated significantly shorter operation time and hospital stay. There were no significant differences in short-term mortality and major complications between two groups. The off-cath group provided significantly better long-term mortality compared with beating heart. The main causes of late death in beating heart group were non-cardiac death. There were no significant differences in long-term MACE between two groups. The off-cath group provided significantly better long-term mortality, but the main causes of the late death in beating heart group were non-cardiac death. Based on the information, there was the possibility that the different preoperative comorbidity causes this result. Study limitations. This study was a single center retrospective study involved a small sample size. The choice of off-cath or beating heart was based on the surgeon's discretion. This is the conclusion. There were no significant differences in short-term and long-term major outcomes between off-cath and beating heart. The off-cath group provided significantly better long-term mortality compared with beating heart group. Thank you.
Any question, please?
May I ask, I'm Dr. Chaywood from Thailand. May I ask you one question for, you excluded the patient with low LV function as less than 40%.
Yeah.
But you have high percentage of preoperative aortic balloon pump. I want to know that what is your indication for preoperative aortic balloon pump? Thank you.
Thank you for your question. And actually, this, now most of the CABG we do off pump. So this is old data, so it's difficult to discuss about this now. But I guess it's now in our institute, especially the very big LVDD or very poor EF, for example, 15% or 20%, under 20%, and very, very acute myocardial infections or like that, we only use the off pump. But this time, maybe off calf don't done by very low EF, like 30% or 20%. So maybe it's very different, the characteristic, so I exclude the low EF.
Yeah, just two questions. You mentioned your average hospital stay as 15 days for off pump and 22 days for an on pump beating heart. Is that not too long a hospital stay for a CABG patient?
It's a long stay in beating heart group.
What's the cause for such a long stay?
Causes. I guess it's difficult to understand what is the real causes, but maybe the intubing time or unit stay, the day of the unit, the staying the time of the unit is very long because maybe it's difficult, but what is the cause is very difficult, but maybe for the bleeding, sorry, I can't.
And second thing, just wanted to ask, what is your conversion rate of an off-pump to on-pump CABG in this study?
Conclusion?
Conversion rate from off-pump
conversion.
study to intraoperative conversion to on-pump study in this study.
It's only one patient in off-cap conversion.
Thank you.
Thank you.
For your question, you mean the hospital stay quite long, even in op-cap, is it right? Or I have a chance to study in Japan. Normally, post open heart patient in Japan have to stay in the hospital long, maybe 1 month, until they can go home without any pain or something.
Yes, yeah, sorry, I can't catch the question. Yes, that's right. It's very common in Japan, so the long time, the 2 weeks and 3 weeks, it's so common. So it's not a very strange things in our country.
Sometimes ASD closure is two weeks.
Yeah.
Yes, sometimes.
Okay, thank you very much. The next speaker is Dr. Mohammad Aslam Hassan. We talk about the total arterial CABG is better than conventional CABG and evaluation of short-term outcome. Dr. Mohammad? No. So we skip to the next speaker, Dr. Shizuya Shintomi.
Okay. Good evening, Mr. Chairman, distinguished colleague, ladies and gentlemen. It's my pleasure to present my review. Where should we go after syntax trial? There is no COI. Japanese guideline changed after syntax trial. Target vessel and graft selection are decided according to DM and target distribution. The aim of the study is to consider the strategy of CABG throughout cases. We enrolled 213 patients undergoing CABG to angina pectoris from 2017 to 2019. This is preoperative characteristics. Mean age was 66 years, and male was 78%. About 50% was DM, and 23% was HD. Mean syntax score was 23, and the detail of syntax classification are as follows. 93% were TVD, and 11% were LMT lesions. We classify the cases to suit Japanese guideline. This is intraoperative status. 100% were off-cap. Last presentation was old cases, so recently the surgery is changing. So now stable angina is 100% off-cap. Mid-cap was 4%. Mean distal graft anemosis was 3.2 places, at most 7 places. Beta was used in 59%, and GA was used 31%. This is a detail of graft anastomosis. We use RIMA to LAD to aim for in situ total revascularization. And we use in situ GA to make anastomosis with RICA. This is postoperative data. The detail of postoperative complication as follows. We use NO in 3 cases, and we use postoperative CAG depending on renal function. Hospital death was 1% due to sepsis. This is a surgical conception of our team. First, we hold a hard team discussion to make a surgical indication with a syntax score, and we aim for all arterial vascularization and no touch aortic. So that we use a beta, in situ GA, and op-cap. First, hard team discussion. As we know, this is syntax trial, 10 years follow-up. Syntax trial reflects more real world than previous RCT. The ratio of complex lesion higher. In conclusion, complex lesion including TVD, syntax score high. In that case, CABG is superior to PCI, and hard team discussion is important. This is freedom trial. Discover whether aggressive medical therapy and the use of DES could alter the revascularization approach for patients with DM and multivessel coronary region. For patients with DM and advanced coronary artery disease, CABG was superior to PCI. Second, all arterial revascularization. This is old but long-term result of BITA. BITA graft procedure improves survival compared with site grafting through 20 years. And the present arterial revascularization trials have studies suggest that with the skeletonization technique, the risk of sternal wound complication with BITA is similar to SITA. This is SUMO's report, and the communicative patency rate as follows. But this article's GA is pedicle. And this is Suzuki and Size Group's paper. This article demonstrated an accurate long-term patency rate for the skeletonized GEA superior to that for a pedicle GEA or SVG. A low-grade degree of target vessel stenosis was the only risk factor for the late occlusion. Third, aortic no touch. This is my major paper, Ruby trial. There are many discussions. On-cap is superior to off-cap, but is it real? We don't think so. There are 4 reasons. First, high-risk patient. This benefit is most significant for a patient with prompt value above 2.5 to 3%, where mortality curves sharply diverge. Second, influence of analytic. Avoidance of aortic manipulation in op-cap may decrease the risk of post-operative stroke, especially in patients with higher stroke risk. In addition, the elimination of CPB may reduce the risk of short-term mortality, renal function, AF, bleeding, and length of ICU stay. Third, effect of renal function. This concludes op-cap is associated with a lower incidence of post-operative renal function failure compared with on-cap in patients with poor operative renal function. Final, op-cap is about several infection. Op-cap is associated with a reduced risk of stroke, AF, and infection as compared with on-cap. This is why we choose op-cap. And to be better, we can do many various approaches like FFR, DTAFM, and NO. This is conclusion. Thank you.
Any questions? I have a question. Have you compared your surgical result with PCI? For example, like in syntax score, low risk or intermediate risk, what is different?
It means in our institution, no, I'm sorry. In the future, yeah, I will try.
And what is the protocol or strategy in your institution for like triple vessel with low syntax score or intermediate score?
Of course, above more than intermediate or high risk. In the case, we choose op-cap. And LMT, like it's difficult to rescue by PCI. In the case, we choose op-cap. And yeah, maybe I think our institutional result is very good. So we tend to choose the op-cap maybe. So it's like depend on institution. So some controversial cases, in that case, maybe we choose op-cap because of long term. It means yeah.
Is there any tips to? Is there any tips to do the op-cap that have a very good
LMT
result?
lesion means
You mean you have any tip or tricks to make your result is very good in the op-cap?
Maybe it's because of op-cap. It means but we use a stabilizer and we use a deep Lima suture. And we don't pour many volume in the operation. Intra-operation, we control the blood pressure to use catecholamine. In the operation, during the operation, the heart is not bigger, so maybe some strategy is getting better.
Thank you.
Yeah.
Thank you very much.
Yeah. Thank you.
The next speaker, Jikiyan Kiho. next one, Koso Morita.
Thank you, Chairman, and good afternoon, everyone. I'll present about this theme today. There is no COI. Transit time from measurement, TTFM, is widely used and considered to be very useful to check the graft in CABG. We evaluated the relation between TTFM parameters and postoperative angio or CT. The number of cases are 189 cases who underwent post-op evaluation, I mean angiography or CT scan, and totally 437 grafts. 98% of cases are OPCAV. We routinely perform complete revascularization. Number of anastomosis was 3.3. Our result is as shown. There is no operative mortality, and morbidity is as shown. Used graft is this, and we did revascularization with all arterial graft for 63% of patients, and used bilateral mammary artery for 61% of cases. Graft distribution is as shown. In this study, we evaluated angiogram of early period, 1 week, about 1 week after operation, and contraindication of post-op angio or CT is CKD and allergy to contrast medium and so forth. We found occlusion or stenosis over 50% in 6 grafts, 4 arterial grafts and 2 vein grafts. PI, pulsatility index, and mean graft flow are shown. PI of failed arterial graft are all below 5.0, and PI of failed vein graft are above 5.0. By the way, we use a validity system for evaluation. According to reports, we set cut-off value of pulsatility index 5.0 and mean graft flow as 20 millimeter per minute. This shows result of TTFM of each graft. There is no significant difference among each arteries. Mean graft flow of saphenous vein is greater than the arteries. This shows scatter plot of mean graft flow of all grafts, I mean including artery graft and vein graft. Blue dots are patent grafts and red dots are failed grafts. We found significant difference between patent grafts and failed grafts. I mean, patent grafts are larger than failed grafts. And about PI of all grafts, there was no significant difference. This shows result about arterial grafts, mean graft flow of failed grafts were all above cutoff line 20 millimeter, 20 milliliter. There was no significant difference between patent and failed grafts. And about PI of arterial graft, PI of failed grafts are all lesser than cutoff line, no significant difference. There are 9 patent grafts despite of high PI over 5.0, or all 9 grafts were patent, I mean. This is about saphenous vein. We found significant difference. Mean graft flow of failed graft is lower than patent graft. And PI of failed vein grafts are over cutoff line, and PI of failed graft is significantly higher than patent graft. In summary, grafts with PI higher than 5.0 are all patent, and 2 of 4 vein graft with PI higher than 5.0 had graft failure. But we have a limitation of small number of patients and grafts, especially in failed grafts. And I'll show the cases patent artery graft despite of high PI and low mean graft flow, as shown. The PI was 9.0 flow. The mean graft flow was 16. This angiogram shows, you can show very poor distal runoff. One another case with extremely high PI, this also shows poor distal runoff. Discussion. In conclusion, TTF values relate not only to the technical aspect, but also peripheral resistance, competitive flow, and so forth. So we don't have so many cases in this study, so we have to continue and increase number of cases. Thank you so much.
Any questions? Oh, please, go ahead.
Shun Watanabe, Thailand, Lampang Hospital. Thank you for your presentation. I want to ask you about when you met the higher pulsatile index over 5, your institution reanastomosed first?
Actually, fortunately, we didn't experience reanasmosis, but the problem is whether we should reanasmosis or not. But it depends on the feeling of surgeon. I did complete anastomosis. If the surgeon is confident of anastomosis, we will continue.
So it means you show the 9 graft arterial graft over
5.0, yeah.
That graft is not reanastomosed.
Yeah, not
only finish if they're confident.
Yeah.
Thank you.
Of course, we have to consider the preoperative angio.
Another question?
You showed that you have accepted a PI value of 5. When did you plan to revise in this? And you didn't tell us how many graphs you have revised, seeing the PI value or flow.
Sorry.
PI value. When did you decide to revise this graph?
Yeah, revise.
Revise.
You're talking revision of graft.
Revision,
Nothing.
You didn't revise any of this graph, right?
Yeah.
Okay, thank you.
Thank you.
Okay, thank you very much.
So let's move to the next speaker, Dr. Shao Wai Cheng. With the topic of effect of previous coronary stenting on the outcome of subsequent coronary artery bypass graft.
Good afternoon. My dear colleagues and Mr. Chairman, first I'd like to thank the Society for giving me this opportunity to share our research. It's my pleasure and pleasure to present our work. According to current clinical guidelines, the CABG is still the standard treatment for advanced coronary artery disease. A pool meta-analysis of 11 randomized controlled trial with over 11,000 patients demonstrated that the CABG has a mortality benefit over PCI. However, the real-world data reveal that the past 15 years, the total number of CABG decreased over 50% in the United States. In the meantime, the percentage of patients has prior PCI before CABG increased from 20% to 25% in the United States, according to ASCVTS database. The current evidence reveals that from meta-analysis, the prior PCI associated with a negative effect on shortened survival after CABG. But no long-term mortality and major adverse cardiovascular events were reported by large population-based study. Therefore, the aim of this study is to investigate the effect of previous coronary stenting on the long-term outcomes of subsequent multivascular CABG. The data source of this study is Taiwan National Health Insurance Research Database, which was derived from the single-payer entry program. Nearly the entire population of Taiwan has covered by this program since 1995 with longitudinal follow-up. Therefore, it's a suitable platform to study the long-term outcomes after surgery. We recognized patient baseline data, surgical detail, including previous coronary stents according to ICD-9 codes, Taiwan reimbursement codes, and medical supplies codes. The outcome entries are composite outcome with all-cause mortality, acute myocardial infarction, and revascularization. We used propensity score matching to reduce confounding factor before comparing the outcomes. Next, I'd like to show you the study design. We have over 33,000 patients who received CABG for more than 3 grafts. Then we divided our population into 2 study groups according to whether the patient received previous coronary stents. Finally, we have approximately 3,000 patients in each group after propensity score matching. Results. This slide, I'd like to demonstrate the epidemiology data in Taiwan of CABG with or without a previous coronary stent. As you can see, the number of total CABG has decreased during study period. However, the percentage of previous coronary stenting has increased. That's demonstrated in red bar. And furthermore, the number of previous stents has increased from around 1 stent to 2 stents before CABG. This slide, I'd like to show you the baseline data. The first column indicates the variables including age, gender, and comorbidities. It's a high-risk population of CABG in Taiwan. We use propensity score matching to balance the difference between groups. As you can see, all the variables are well balanced after propensity score matching with STD less than 0.1. And there is no significant difference in surgical detail, previous medication, and hospital level, and the hospital volume after matching. In previous coronary stenting group, the patients received more than 2 times previous coronary stenting in around 20%, with an average of 1.8 stents before CABG. This table, we demonstrated a shortened outcome of our study. There are no significant difference in postoperative complication between 2 groups, but the previous stent group do have a higher risk of 30-day mortality than non-stent group. Next, I'd like to show you the long-term outcomes. This figure demonstrated the survival analysis of all-cause mortality. And the 2 groups, the result demonstrated they are comparable between 2 groups. For composite outcome, the previous stent group had a little higher risk of composite outcome comparing to the non-stent group. After further analysis, we found that the difference in composite outcome is primarily driven by the revascularization, in which the previous stent group has a significantly higher risk of revascularization. Then we did a subgroup analysis for the revascularization. This figure presents the revascularization stratified by previous coronary stenting times. And the result demonstrated the more the previous coronary stenting associated with a higher risk of revascularization in dose-dependent manner. When stratified by number of total stent before CABG. The results also demonstrated the more coronary stents before the CABG associated with a higher risk of revascularization, also in a dose-dependent manner. In conclusion, our study demonstrated that the previous coronary stenting associated with a higher 30-day mortality, but did not affect long-term survival. It's associated with a higher risk of revascularization during follow-up. Multiple previous coronary stenting procedures are associated with a higher long-term adverse outcome. Thank you for your attention.
Please, Asai.
Asai from Japan. A very interesting study and very impressive. Your conclusion said that previous stenting group having had more revascularization-driven outcome and also higher mortality. But there's no change of the incidence of myocardial infarction or?
Because the limited time, I didn't show you the whole data. But the rates of acute myocardial infarction is a little bit higher in stent group, but not reach statistical significance.
Okay. Have you investigated the reason why? Because that's a patient who had a previous stent but not doing well. It's going to have an operation, maybe even a stented area. Or stented area is intact at the time of operation. However, in the later, it may develop a new event. We were just wondering why. You can give some statement or just your impression?
That's a great question. I don't have the answer for the data, but in my opinion, first, the previous coronary stent may limit the target of anastomosis. We surgeons encounter patients with previous coronary stents, like full metal jacket, so that will limit your choice to bypass the coronary artery. So that maybe enforce you to do anastomosis in a small vessel. and that may be have negative effect on the long-term outcome like revascularization. Second, imagine your cardiologist colleagues just put 3 stents in a triple vessel disease in LAD, circumflex, and RCA. 2 years later, the patients got an AMI and sent to the emergency room. And the angiography revealed that the LAD with 70% stenosis and the circumflex with 50% stenosis and the RCA with 30% stenosis. That's put, your colleague said that it's not unusual in our institution. Your colleague said that it's your turn to do the CABG. What would you do? Maybe you must to bypass the LAD with Lima, sure. And maybe you will graft the circumflex artery, but how about the RCA? If you choose leave it alone, maybe the disease will progress. The instant stenosis will progress. If you choose to bypass this graft, the competing flow will have an impact on your patency. Maybe you will have early graft failure. Then the instant stenosis progressed, and the patient maybe need revascularization. That's just my impression.
Yeah, we're just interested in a further study for maybe next year, in a further investigation, what the bypass procedure was, because this data is so whole comprehensive to the whole your Taiwan, the national insurance. Very important study. Thank you very much.
Thank you for your comment.
Thank you. The next speaker, Swapril. Dr. Swapril Deshpande.
Good evening, everybody. Thank you, chairpersons. It's really an honor to be here at the ASCVTS. Yesterday, we had a nice fellowship and togetherness at the Congress dinner. Today, I am thankful that I'm able to talk about some innovation which we have tried to do at our center. I am Dr. Swapnil Deshpande, Senior Consultant Cardiac Surgeon, representing my center, where we are doing quite a number of hybrid therapies for systemic atherosclerosis, as well as non-atherosclerotic diseases for last 6 years. The real concept started when I was doing my residency in general surgery, and I accompanied my father for a convention in Beijing, China, where there was an international symposium on hybrid approach to heart diseases in 2008 at Fuwai Hospital, Beijing, where I was not knowing anything about hybrid. I didn't even know where there was a hybrid surgery about cardiac hybrid surgery. But I was surprised to find out that there had over 200 papers and presentations on hybrid cardiac surgery. So that really fired my father and me to do something, because that is going to be the future of cardiac surgery. That's what we thought. So with that, at our hospital, Dr. K.G. Deshpande Memorial Center, we established a hybrid operation suite in 2010, which incidentally is the first of its kind in India, our country, first in SAARC countries, and 37th in the world. With this, the surgeries which were possible were completion angiogram after CABG, which we do, and all 125 cases which we have done for completion angiogram were all minimal invasive cardiac surgeries, in which incidentally we had to do 2 graft revisions. 1 stage CABG and aortobiofemoral bypass, extra-anatomic, we had 13 patients, for which instead hybrid surgery, hybrid cardiac cath lab is not required. 1 stage CABG plus renal artery stenting. Now the 15 cases, we have a 16th already done now. Hybrid coronary artery revascularization, that is, we did a MICS left-sided CABG, and the cardiologist stented the right side. one-stage pulmonary artery thrombectomy and IVC trans-RA IVC filter placement. And we do all our minimal invasive cardiac surgery cases. We've done total of 154 cases in our hybrid OR. And we have already done a TAVI and a transcatheter mitral valve in valve, one case each. So taking about the first subset, that is the one-stage CABG and aortobiofemoral bypass, we have a big number of patients there, big number of patients and good follow-up. We have done 13 patients, in which the patients have coronary artery disease as well as an aortoiliac disease. The first patient which we did was a gynecologist in our city who complained to us that he had bilateral claudication. So on investigation, he had absent pulse on both femoral arteries. And while his workup for revascularization of the lower limbs, we found that the ECG had a global ST depression. So we did his coronary angiogram and we were surprised to see that he had a unprotected left main disease. So what we did was, that's one of the angiograms of one of the patients. That's the CT angiogram showing a tight bilateral aortobiofemoral disease. That's the intraoperative photograph showing the Gore-Tex 8x8x8 ring graft, which is being sutured to the ascending aorta along with the proximal. That's the skeletonized rima. And then we tunneled this tube graft preperitoneally into both the groins and did a femoral anastomosis with the ring graft. It has been accepted in the Innovations Journal in Boston 2014. And this is the check angiogram which we have done 3 months back, which shows a patent tube graft and the patent coronary conduits. The basic idea is we have the ascending aorta in front of us, and we are quite adept at suturing and doing anastomosis on the ascending aorta. So it is much easier to do an anastomosis on the ascending aorta than to find out the axillary artery or the subclavian artery. And also, because both lower limbs have big distal runoff, this graft is going to be patent and giving good long-term effect to the patient. We do all our minimal invasive, second set of subset of cases is minimal invasive cardiac surgery. We do all our cases in hybrid OR. Femoral cannulation is done under fluoroscopic guidance. This is the femoral artery cannulation, which is most of the times easy and does not have much complication. But the trouble is with the femoral vein cannulation. You can see that as we move the guide wire ahead, it can go to different areas. And if your anesthetist is not very adept at seeing the guide wire coming into the RA through transesophageal echocardiography, you may not at times be 100% sure that your venous cannula is in proper position, and that can lead to reduced drainage and increased return in the heart, and that can really complicate your surgery. So it's very easy to cannulate it under fluoroscopic guidance and be 100% sure that it is reached the RA and RA-SVC junction. Till now, we didn't have any vascular injuries in any minimal invasive cardiac surgery cases because we have been able to do under vision completely. 2 patients required femoral artery embolectomy after completion of surgery. Then another subset of patients is a one-stage CABG plus renal artery stenting. We have done total 16 number of cases. All cases underwent off-pump CABG. Of these patients, during investigations, we had 15 patients who had a significant unilateral renal artery stenosis, and 1 patient had a bilateral renal artery stenosis. Incidentally, the patient who had a bilateral renal artery stenosis also had infrarenal abdominal complete occlusion and absent pulses on the lower limb. This first line diagram shows the operative program which we have done for this. We did a CABG as well as right renal artery stenting. And this is the patient in which the patient had bilateral renal artery stenosis plus coronary artery disease plus an infraabdominal stenosis, in which we did a CABG, bilateral endarterectomy stenosis stenting, and a aortobiofemoral grafting. That's a hybrid lab in which after completion of the CABG, we keep the chest open, we protaminize the patient, we do all the, we don't we don't reverse the heparin, keep the chest open. IR consultant does the renal artery stenting, that's the check shoot for the right renal artery, and that's the shoot after doing the renal artery stenting. This is a patient in which the patient had a bilateral renal artery stenosis. So we planned her patient was, before doing a CABG, through a trans right brachial artery, we did a bilateral renal artery stenting. And after that, we did a CABG for this patient. This was well accepted in most of the conferences where we presented our data. Regarding hybrid coronary revascularization, we have just done 3 cases because we couldn't get on consensus with our cardiologist to whether to stop the clopidogrel aspirin or whether to load the clopidogrel aspirin preoperatively. So we had just 3 patients in which we did a thoracotomy, Lima to LAD, and then stented the right side. But now we have got pretty well adept at doing multi-vessel CABG through thoracotomy, so we have stopped doing a hybrid coronary revascularization, and we have just now going into a multi-vessel minimal invasive CABG. Then coming to the TAVI program at our center, we have done the first transcatheter mitral valve-in-valve of the state and the 16th of the country, and we have done the first Evolute R for TAVI plus coronary artery stenting at our center. This is the coronary angiogram picture showing proximal LAD lesion. She had a gradient of 110 by 60 millimeters of mercury trans-aortic gradient, EF of 30%, and a significant single vessel proximal LAD lesion. So first, what we did was we stented the proximal LAD, and then we performed trans-aortic, transfemoral Evolute R self-expanding implantable valve, and then using the proglides, that's the femoral cannulation, which shows a good coronary with no leak, and there is no narrowing of the femoral arteries. Other potential uses which we are thinking of are one-stage MAPCA embolization and intracardiac repair of TOF, descending thoracic aorta and abdominal aorta aneurysm with debranching, and multiple muscular VSDs which are difficult to reach through surgery. So we can just put this patient, open this patient, put him on pump, and then do a muscular VSD device closures. So to conclude, hybrid cardiac surgery is a one-stop treatment for multiple problems of patients who come with multiple problems. Cheaper as one admission treats most of the diseases. It requires treatment, teamwork, and understanding of the procedures of the others so that complications can be avoided. Thank you. Or in Thai, should I say khapun kha? Thank you.
Any question? I have a question. Do you have patient who have like acute kidney injury or acute renal failure after the procedure, or incident of the renal dysfunction after the procedure?
For stenting, renal artery stenting? Yeah. Luckily, we didn't have any. But good important thing is we have to hydrate these patients quite well, because bilateral renal artery stenting, we had just one patient. Protocol was we do stenting, we hydrate the patient quite well during the surgery, because off-pump CABG, most of the surgeons tend to keep the patient negative or give less volume, but in such patients, you have to hydrate these patients quite well, because if you don't hydrate these patients, then they land up into acute kidney injury. That's the thing which we do, most important thing.
Okay, thank you.
Thank you.
for the last speaker, Dr. Yuki Wada, with the topic of long-term outcome after surgical repair of coronary artery fistula in adult.
Good evening. Thank you for giving me the opportunity to present our study. There is no COI. It is the introduction. Coronary artery fistula is rare cardiac anomaly. It is an abnormal communication between coronary artery and any cardiac cavity, coronary sinus, pulmonary artery, or other great vessels. The incidence of coronary artery fistula is approximately 0.002% of the general population and are detected in 0.25% of patients undergoing cardiac catheterization. This right image shows coronary artery to pulmonary artery fistula. The middle image shows aneurysm of coronary artery to pulmonary artery fistula. The left image shows coronary artery to coronary sinus fistula. The objective of this study is elucidate long-term outcome following surgical repair of coronary artery fistula in adults in our institution. This is a single-center retrospective study. We evaluate 30 consecutive patients undergoing surgical repair of coronary artery fistula in our institution between 2008 to 2019. There are 30 patients, 5 cases are male. Mean age was 67.3 years old. There are 3 types of coronary artery fistula in our study. One is coronary artery to pulmonary artery fistula. Another is coronary artery to coronary sinus fistula, and the other is coexistence of both types of fistula. Coronary artery fistula, coronary artery to pulmonary artery fistula is most common in the present study. QPQS was measured 7 cases. Mean QPQS was 1.52. Coexistence cardiac disease were aortic, mitral, and tricuspid valve disease. Ascending aortic aneurysm also included. 7 patients underwent surgical treatment for coronary artery fistula alone. Site of origin were right coronary artery, left coronary artery, aortic arch, and left internal thoracic artery. Drainage site is were pulmonary artery and coronary sinus. There were 3 cases of aneurysm of coronary artery fistula. All procedures were conducted under cardiopulmonary bypass. Surgical procedure for coronary artery fistula was as follows. There were 6 cases of epicardial ligation alone. There were 5 cases of epicardial ligation and direct closure through pulmonary artery incision. There are 1 case of direct closure through coronary sinus incision. There was 1 case of patch closure through coronary sinus incision. There was no perioperative death and complication. However, 1 patient showed poor contrast enhancement of RCA number 224. During the follow-up, the patient was asymptomatic with no cardiac event. Mean follow-up were 4.1 years. No patient died during the follow-up. 2 patients had cardiovascular event. 1 patient underwent thoracic aortic surgery for dilation of ascending aorta and aortic arch 2 years after primary surgery. Another patient present proximal arterial tachycardia 9 years after surgery. There was no coronary event. There was no patient with post-operative myocardial infarction in the present study, but myocardial infarction is severe complication after surgery. Several studies Several studies have reported post-operative deaths because of myocardial infarction after surgery for coronary artery fistula. There are two types of myocardial infarction after surgery. One is early myocardial infarction. Another is late myocardial infarction. The occurrence of early postoperative myocardial infarction can be explained by removal of important coronary artery branches in the case of ligation or excision of coronary artery fistula. The management of early postoperative myocardial infarction evaluate myocardial infarction during the operating using by TE and ECG. If myocardial infarction was suspected, you need to consider CABG. Late postoperative myocardial infarction can be explained by the late native coronary artery thrombosis because of low flow and dilated coronary artery. The management of postoperative late myocardial infarction is using anticoagulation. One patient showed poor contrast enhancement of RCA number 224 in the present study. The patient received anticoagulation therapy with warfarin. We typically use warfarin in the dilated coronary artery cases. In conclusion, coronary artery fistula has several anatomical variations and coexistence cardiac disease. Long-term outcomes following surgical repair are satisfactory in our institution. Prevent post-operative myocardial infarction is important for good outcome of surgical correction of coronary artery fistula. Thank you for your attention.
Any questions? Okay, thank you very much. Thank you very much for ladies and gentlemen for your time and making this session is fruitful. Thank you.